Hey everybody, welcome to our boards and interview prep courses that we've compiled to help you kind of get through these difficult times and challenging days ahead. Today's the intro course to discuss the big topics that'll be covered in both your January boards coming up here in a couple days, and then your interviews also in January. There's a lot of hot topics that we want to make sure you get, crossed off your list to study and make sure that we're all prepared for those big hitting topics that you may face in the upcoming weeks. Don't forget, before we move on, like this video, subscribe to the channel, and turn on those notifications. Make sure you're as up to date as possible for all our interview prep videos and board prep videos that we have in the upcoming months or weeks too. If you have any questions specifically, just message us. We'll address them either in the next video or directly. So without further ado, let's get started. All right, let's get onto these high yield questions that you'll find a lot on your boards. Make sure you're studying really well on these big topics. So for antibiotics, we want to make sure we know what kind of antibiotics have good MRSA coverage, which ones are Pseudomonas specific, both IVs and orals, what kind of antibiotics are given preoperatively, and then what kind of antibiotics are given for open fractures and all of the different classifications, and specifically what is added when it's a dirty or long-standing open fracture. Matrixectomies, the different kinds of procedures that are performed for those permanent and temporary matrixectomies, both surgically and using chemical compounds. When we come to fixation, we want to make sure those AO principles are, in our minds and able to reiterate them really well. The distance of displacement necessary for ORAF, both angulation and that displacement measurement. Why do you denude and fenestrate or fish scale those joint surfaces when we are fixating for a fusion? Make sure you want to go over the lag technique and the 3 ways to achieve this lag technique, and then the steps of screw insertion, and utilizing when you're studying, pick a drill or a screw size, and then what kind of sizes you would use for all of the steps of the fixation. The types of plates are really important. We have a video on all this stuff in our channel if you want to take a look at that and you're a little apprehensive of knowing everything there is with the AO principles. And then make sure you know the parts of the screw. This is just a little diagram. You can take a screenshot of this showing the different kind of thread diameters, the patterns, the pitch, and then the labels of what kind of screws they are. For Hammertoes, sequential releases are really important to know those steps and be able to reiterate those verbally. The derotational arthroplasties on the 5th toe, for instance, and what direction those incisions are made in order to derotate that toe. The types and causes of hammertoes, we're all aware that there are 3 different types, but you want to make sure you are well versed in which deformities cause which hammertoes. That first person to describe an arthroplasty, Dr. Post, is always a nice little interview prep question. Differential diagnosis for second MPJ pain. There's a lot of things that they can throw at you, whether or not it's a clinical description or an x-ray, and you want to make sure you know those differentials. What's the course of action for a post-op white toe? What's the course of action for a post-op blue toe? Are both, kind of high yield questions to be asked in interviews. And then the anatomy of the flexors at the DIPJ and PIPJ insertions, what the origin is, etc. For bunions, you're always going to be asked about angles, so make sure you know those front and back. Name as many procedures that you can, especially when you're practicing for interviews. There's a ton of different bunion procedures. You're not going to know all of them, but you do need to know a nice handful of head procedures and distal procedures, base procedures, fusion procedures, etc. Causes of hallux varus, surgical and non-surgical. Those are big high hit questions on interviews. First MPJ fusions. What kind of fixation is there out there? What would you prefer given your experiences on your externships? And then what kind of fixations maybe you haven't seen but need to know about. The angles and position of fixation of first MPJ fusions, and of course the most common complications and how to address those if you're faced with a non-union, a malunion, etc. For fifth metatarsals, types of bunionettes and types of bunionette procedures. What is the vascular supply of the fifth met base versus the shaft, and how that leads to complications with Jones fractures, etc. And then know what a nutcracker fracture is, and maybe even review those classifications and then nutcracker fractures as well. Midfoot fusions. Everyone gets asked this question at least once during the course of interviews. And what is that depth of the first metatarsal cuneiform joint? What kind of fixation can you utilize for Liz Frank and know the difference between ORIF versus arthrodesis? The relationship of the second metatarsal base to the intermediate cuneiform, where those articulations are found, are a good thing to review. The relationship of the fourth metatarsal base to the cuboid, also kind of a good anatomy review of midfoot. For the calcaneus, the other injuries with calc fractures that are common, always making sure if you're given a calc fracture that you're asking for proximal x-rays and possibly spinal x-rays given the mechanism of injury, what kind of imaging you're going to see, and what the important surgical restorations for the calcaneus are, especially the angles that can be asked. What's Mondor's sign? The plantar bruising that we see with calcaneal fractures. Make sure you can say that and reiterate that it is for calcaneal fractures or high impact fractures. Will foot varus or valgus happen after a calc fracture? That's a good little, quick TQ to get. The angles, obviously, with calcaneal fractures, knowing the angles, what's normal and what's abnormal, what's increased with a calc fracture and what's decreased with a suppression fracture are important. And then knowing which fragment is the stable fragment, quote unquote, that we're always asked on tests, boards, and then also in interviews. Hawkinsign are always big to ask on talar fractures or post-talar fractures. Is it a good sign? Is it a bad sign? The treatment of osteochondral defects on that talar dome and the classifications of those osteochondral defects. Always good to know, especially on boards questions. Those are usually the pictures that they show, OCDs, classify it. And then with interviews, same thing. What is the blood supply to the calcaneus or to the talus? I'm sorry, and what are the chances of AVN with the fracture and all those different classifications and the chances of AVN. Knowing those are really important to kind of guide you through a lot of your interview questions. For Achilles tendons, you want to make sure where you're making that incision and why you're making that incision where you are, knowing that the blood supply to that area is compromised, and planning your incisions appropriately. Know your angles, know what a Hoke hemisection is, the complications and re-rupture rates of surgical versus non-surgical repair of rupture. Essentially knowing that your complication rate can be high, your re-rupture rate of surgical versus non-surgical can also be high, and just knowing those up-to-date data. Repair if there's a large gap, and then the different alterations you can make to your primary repair, whether it's a turn down, whether it's a tendon transfer, whether it's an autograft or allograft, just knowing those as options when you're getting into your boards questions. With ankle sprains, ligament anatomy and testing for ruptures is always important to review. The locations to palpate for acute pain versus the chronic pain, and then just review those auto-raw rules. For some reason, those always pop up, and knowing which tests are appropriate for lateral ankle instability. Ankle fractures are always hit. They're hit on boards, they're hit on interviews, and knowing the classifications and knowing multiple different classifications is really important. Of course, you can always go with the Weber, which is, the quote unquote easiest, but there are a lot of treatment decisions that can be made with Log Hansen. So you want to make sure you're well versed on that as well. But anyway, with ankle fractures, the plate, placing the plate or interfrag screw first, you want to make that decision based upon the x-ray that they show you. Start medial or lateral. Again, it kind of depends on who you talk to and which rotation you did, but knowing the role of the fibula and bringing that into place, whether or not that's more appropriate to do first or second, just based on the fracture pattern. Vassell's rule, syndesmotic ruptures. Always remember the multiple ways to test whether or not that syndesmosis is ruptured. They always ask that, and they always ask for a second test just in case. They're trying to keep you on your toes. Overlap of the tibia and fibula on the AP and mortise, making sure you're reviewing the measurements for those, and then always know those associated fractures that occur with ankle fractures as well, whether it's a fifth metatarsal fracture, avulsion fracture, medial malavulsion, or talus fracture. For arthroscopy in the ankle, we always like to ask portal locations, so it's important to review those anatomical landmarks, making sure, as you answer those questions, thinking about that anatomy and where you want to put those incisions for appropriate anatomical locations. What is Bisset's ligament? I feel like that's one of those, you either know it or you don't. And for those people who don't know it, they always remember it after they're asked. Benefits of arthroscopy versus an open surgery. Obviously with incision planning and minimal incisions, arthroscopy is preferred if possible, but just be able to kind of reiterate some of those benefits of arthroscopy versus open procedures. The most common types of coalitions and the ages where those are seen are always asked on boards, and I feel like that's one of those, you memorize once for a test and then forget about, so you want to make sure to go back and try to get as much information in your head as possible for those. What's a coalition versus a bar? The radiographic signs that you see, not necessarily always are shown the actual x-rays, but descriptions of them on boards. So you want to make sure you're aware of the common coalitions you can see in the foot, and how to prevent a reunion of a CN bar coalition after a resection is always a high yield question as well. Moving on to Flatfoot, so we have the multiple different tests, both clinically, radiographically, and of course with further imaging that you want to make sure you're reviewing. So knowing what the single heel rise shows, and how you test for that, knowing what a cora is, not just the terminology, but what it actually means, where that center of the deformity is, what plane that deformity is, whether it's a single plane, double plane, or triplanar. The procedures for flexible versus rigid, always good to review those ACFAS guidelines. The Evans plane of correction, when you're making that osteotomy for a flat foot, what plane is that correction done in, and then what's that distance between the CC joint and your osteotomy that is ideal for making that. Gastroc recession types, I feel like that's one of those minimum hit, but when it's hit, you want to make sure you're at least well versed in some of them, so you can kind of do a process of elimination for gastroc recessions. And then the order of reduction and fixation for a triple arthrodesis, and which joints are responsible for the most motion. That's an easy search to find. Just make sure you're doing that, proximal to distal fixation, corrections with the appropriate fixations. Cavus foot, always know what that Coleman block test is, and how that determines flexibility versus rigid. Know some causes of Cavus foot besides the iatrogenic, making sure you know a few of the muscular deformities, especially CMT. If they're going to ask a question about Cavus foot, most likely that patient's CMT disease is going to be asked about as well. The order of muscle atrophy in CMT, the types of equinus that's known or seen in that, and then the procedures for both a flexible, a rigid, and then the forefoot driven versus rear foot driven Cavus foot. External fixation. A lot of different things to go dive in on in this. I think knowing the basics for external fixation will probably get you through most of your interviews and boards. But these 4 things are what we figure is probably the most high yield. When do you use a delta frame, and when do you use other kinds of fixation? When's it appropriate? I think the easy answer to that is open fractures equal delta frame, and everything else circular. What the safe zones are, talking through where you put your pins, both in the tibia, distal ankle, and the foot. A quick review of that will, remind you of where those safe zones are. Pin care, whether or not, there's a lot of different ways to skin a cat, but pin care is one of those. How would you take care of the pins afterwards? Easy answers. And the types of external fixation. So just pretty much knowing the difference between monorails, uniplanar, multiplanar frames, delta frames, and then hybrids, which are combinations of those frames. Osteomyelitis, the types and causes and organisms, that can go, that itself is a huge lecture, but the types of osteomyelitis seen most in diabetics is important. Knowing what kind of antibiotics to use, how long to use those antibiotics, IVs versus oral, given the state of the osteomyelitis, whether or not it's being resected or just being treated with IVs, is kind of going to get you through those questions. Charcot is another beast of questions. When you're shown an X-ray of that, whether it's on boards, whether it's on an interview, make sure that you do the biggest workup you can. Ask as many things as possible, whether it's what the MRI's read is, what the CT scan is, if there's a bone scan, and then being able to formulate a treatment plan. And then the classifications are always a good thing to review. What the skin temperature is supposed to point you toward if it is not infected. When they're asking those questions, especially on boards, the temperature change increased with those pulses are the red flags that, oh, maybe we are talking about Charcot. And what's the gold standard of treatment? Obviously offloading and immobilization is our gold standard, but also what kind of treatment you want to plan after that Charcot calms down. Congenital conditions, the planes of equino varus, the order of casting, what Ponseti technique is, the actual Ponseti technique, congenital vertical talus versus a calcaneal valgus, and knowing which one is rigid versus flexible. That'll help you get through those pediatric cases that maybe you weren't as versed in clinic or on your rotations, but those are obviously the telltale signs whether or not it is a rigid or flexible deformity. Non-invasive vascular studies, really the thing to remember is what kind of pressures are required to heal wounds, what a blunting versus a dicrotic notch means when you're looking at the the waveforms. Blunting obviously is bad, and dicrotic notch is good. What the pressure drop is significant between the levels of the segments of the pressures taken, and then just know what the normal ABIs are. 0.9 to 1 being our normal range. Above 1, that's when you start thinking about calcified vessels, and then the mild down to severe PVD when it drops below that 0.9. And then just a couple miscellaneous things, puncture wound classifications and the organisms that can be seen with puncture wounds, the effects of a posterior tibial block on vessels, the Jones compression versus a Jones cast, how are those applied and what kind of pressures are seen with those, fracture blisters and what that means when you're timing surgery. That's when you're talking about, immobilization with external fixator versus a cast, and then planning to delay that surgery and how long do you delay that surgery. The process of wound and bone healing, knowing those key words, the process of, the process of skin graft taking, also really important to kind of review right before your interviews. The ways to diagnose and treat compartment syndrome, knowing that that's an emergency, knowing that that needs to go to the operating room if those compartments and pain is getting out of control. And then the local nerve blocks, what's the max dose of xylocaine? What's that max dose of bupivacaine? All right, so hopefully that helps. With your boards coming up in a couple of days and your interviews coming up in a couple of weeks, kind of gives you a little taste of things to review right beforehand. Make sure you hit them hard. Good luck to everybody. And again, like, subscribe, and turn on those notifications. We have another couple videos coming out, especially before interviews. So make sure you're not missing out on anything, and we will see you soon. Thanks for joining.